Good evening, everybody. This is Dr. Bill Tulo, Medical Director at Oculus, and welcome again to our webinar series. Tonight, I'm extremely excited to have Dr. Jason Jedlicka present the Pentacam, the indispensable tool for the contact lens specialist. Dr. Jedlicka is a clinical associate professor at the Indiana University School of Optometry and the director of cornea and contact lens service. He's a diplomate in the American Academy of Optometry's Cornea, Contact Lens, and Refractive Technologies section, a fellow and past president of the Scleral Lens Education Society, and a fellow and board member of the Contact Lens Society of America. He's contributed to multiple textbooks as an author on the topic of GP lenses and was awarded the GPLI Practitioner of the Year for 2021. Before I hand this over to Dr. Jedlicka, I just want to let everyone know, if you have questions, please put them in the chat, and we leave some time at the end to answer your questions. And again, join me in a warm welcome. Dr. Jedlicka, take it away.
Thank you very much, Bill. It's a pleasure to be here and to have you all joining us for tonight. I get to talk about the Pentacam, which is an instrument that I've had in my practice for about 8.5 years now and use it on a daily basis. And so I get to talk about how that instrument has found its way into my regular practice and how we utilize it in managing our contact lens patients on a daily basis. So again, just to remind everyone, the difference between a Pentacam and pretty much every other corneal topographer that's out there. The Pentacam is a tomographer, and the difference, of course, being is that instead of reflection-based imaging that we would get with a corneal topographer with a placido disc and rings, the Pentacam does this with Scheimpflug imaging. It's going to take actual cross-sectional images of the anterior segment of the eye. It's going to rotate a few degrees, take another picture, rotate, and all that happens within the matter of just a couple of seconds. It will rotate quickly, taking many, many snapshots of that anterior chamber, cornea, iris, lens, etc. And then it's going to construct a 3D model of the eye. So we'll talk just a little bit about that again. This is how the actual instrument works. You're getting that picture, and the red lines on the picture on the right there show you those cross sections you're getting through the cornea and the anterior segment of the eye. And you'll notice again that those cuts or those images go out past the cornea. So we're actually getting out onto the limbus and a little bit onto the conj and sclera. So that's really helpful in getting us information about the entire cornea, not just an 8 or 10 millimeter section of the central cornea, but it's giving us a lot more information. And that's part of one of the benefits of Pentacam that I think you'll find is helpful in managing contact lens patients. So again, the individual images that it takes, there's 25 or 50 images it's going to take. It's going to combine those into a 3D model, as you see on the upper right picture. We got front of the cornea, back of the cornea, then iris, lens, etc. All these images go through the central cornea, which is the most important part. So we're getting the densest sampling of information from the most important vital part of the cornea, which is the center. But again, even out at the very periphery, we're getting information in about 10-degree steps. So we're filling in quite a tight window of the cornea with that. The coverage again is nearly limbus to limbus, and it certainly can be entirely limbus to limbus depending upon how wide our patient opens their eyes up. Whether we get that upper and lower lid out of the way is part of that. The measurements are not tear film dependent. And of course, that's can be very critical. It means that even on a patient who's got superficial epitheliopathy, maybe they've got a keratoconus and they're wearing a lens that's creating some stippling, maybe they have dry eyes and we want to scan their corneas for a possible scleral lens to treat with, etc. We don't have to worry about that tear layer disruption affecting the data we get back as far as the shape of the cornea itself. The Pentacam is going to give you, again, true elevation data. And the difference being is that with placido disc topographers, you're getting curvature data. You're getting information about how the curvature of the cornea changes the shape of the rings it reflects. And the difference with Pentacam is you're getting elevation data. And you might say, well, who really cares? Why is that important? And I would just say this, is that for the contact lens practitioner in 2022 compared to, let's say, 1992 or 2002, we do a lot more with scleral lenses. We do a lot more Ortho-K in many cases. And the reality is we're moving towards more of a sag-based fitting of a lot of our important types of specialty lenses. And so having elevation data, true elevation data about the cornea and the sclera is kind of the way we're moving with imaging the anterior surface of the eye, the ocular surface shape, getting that elevation data. We can always construct curvature maps from elevation data, but we can't always get true, accurate elevation data created off of a curvature map. So understanding the differences in the instruments is helpful. There are several types of Pentacam models out there. There's the Pentacam Basic, the HR, the AXL, and the AXL Wave. Most of my life, I've worked with a basic Pentacam or a Pentacam HR. Just in the last several months, I've had the real pleasure of having a Pentacam AXL Wave to work on. And so some of the things we'll talk about tonight are available on all of the instruments. Some of them are exclusive to certain models, and we'll try to differentiate that. But the basic core function of corneal tomography is universal between the instruments. So let's talk about the contact lens specialist. And a lot of contact lens specialists are, or all of us really, are going to see patients with anterior segment disease. Now, some people are maybe a little more comfortable with being the primary eye care provider for someone with an anterior segment disease like keratoconus or corneal degenerations or dystrophies, et cetera. Personally, I enjoy managing anterior segment disease just as much as I love the prescription of contact lens correction for those eyes. And so for me, I love both aspects of managing my patient's disease and being confident that I'm as good a provider for them as it pertains to managing their disease as I am their contact lenses. Now, not everybody may be that way, but certainly if you want to practice at that very highest level and say to your patients that I'm fully confident in my ability to manage your corneal disease, your keratoconus, your corneal transplant, whatever that may be, it helps to have the instrumentation that is best at detecting diseases and monitoring for progression, et cetera. And that is just what a Pentacam is. The Pentacam for the anterior segment is kind of like a retinal OCT is for managing a retina or glaucoma. And so to have that instrument that gives you that data, it doesn't replace your ability and your skills, but it just enhances them and makes you more capable of being a better provider for anterior segment disease care. The contact lens specialist is also going to fit a wide variety of soft and GP lenses as well. Just because I may be a corneal specialist doesn't mean I'm not perfectly happy to fit that 3 diopter myope with regular corneas and some soft disposable lenses. But I want to be really good at that. I don't want to just pick off any old lens and put it on that eye because it's the lens I have the best markup on, or because it's whatever is new and I want to play with it. I want to fit my patients in lenses that fit them the best, because that means that I have the greatest chance of that patient being successful with their lenses, because not only have I picked a material and a modality that's best for that patient, but I'm putting them in a lens that actually fits their cornea properly. And to do that, I've got to measure their cornea to know what it is so I can do that. So again, to fit proper fitting basic lenses, we need to be able to have that information about the anterior segment. And then the contact lens specialist of today is probably in many cases fitting Ortho-K lenses and scleral lenses. And we should be able to screen out those patients who are not very good candidates for Ortho-K before we embark upon the process, because it may be down the road it's hard to detect issues as we reshape that cornea with lenses. We also probably benefit from having full corneal data if we're going to fit Ortho-K lenses to a very high level. And the same with scleral lenses. We'd love to have some scleral topography, scleral shape information to better fit our scleral lenses. We also might benefit from having integrated software to allow us in designing lenses and modifying lenses, both for Ortho-K and sclerals, right on the instrument that we've measured the shape of the eye with. So let's talk a little bit about the capabilities of Pentacam at diagnosing anterior segment disease. Certainly, the standard of care for diagnosing keratoconus has changed. It used to be in the past, there wasn't much we could do about it, so it was detect it, give them the best correction we could, educate them not to rub their eyes, and just watch it deteriorate over time. That's different now. We've got cross-linking to slow down or stop the progression of many cases. So it's really important now that we catch this in as early as we can. And you really can't make a proper diagnosis of keratoconus on a very subtle case without both anterior and posterior corneal elevation data. And so here's a case of a patient that we would look and say, gosh, is this keratoconus or not? If you just look at the curvature map in the upper left, this is what we've gotten from most corneal topographers. And from that, you really can't tell. As you start to look around, what the other information that the Pentacam gives is we see the corneal thickness is a little on the thin side at 490-ish. We also see the apex is a little decentered inferior temporal. And then as we look at our anterior and posterior elevation maps, we see a slight tendency for a focal back surface elevation. And so we would say, in this case, I would say at least this patient is highly suspicious for a very early stage or at risk of developing keratoconus. And what I haven't told you is their right eye has full-blown keratoconus. So again, a good example of the ability to detect early detection, and should this patient have intervention at this point? Probably so. Differentiating again between subtle cases, here's obviously a case, if you look at the picture on the far left, this is your corneal topography. It certainly looks like keratoconus. As we look at the middle maps, we see our front and back elevation. Our back is more elevated than the front. That is kind of the telltale sign of a corneal ectasia. We've got thinning and bowing of the cornea. It's always going to bow forward because of intraocular pressure. And if our cornea is thinning and bowing forward, then we're always going to have a exaggerated elevation on the back versus the front. It's by definition, it has to be that way. And as you see on the right, we've got our Bell and Ambrosio keratoconus display, and it certainly shows this patient does seem to have keratoconus. Now we could look at another case. Here's another corneal topography. The upper left picture shows us our corneal map, and that certainly looks suspicious for keratoconus as well. As we move through the other types of maps, though, we can see that we don't see much corneal thinning. We see that the apex is fairly well centered still. And we look at our front and back elevation maps, there's very little difference there between the two. And if we stage this out with our enhanced ectasia display, we see as we look at the bottom two pictures, the front and back differences, it's all green. So at first glance, this patient would appear to not have keratoconus. And so we would probably want to monitor or try to figure out what's causing this anterior corneal warpage other than keratoconus. Start looking for other reasons like ill-fitting contact lenses or any other findings that might explain it. Here's a couple other interesting cases. Both of these patients were initially diagnosed by other providers with post-LASIK ectasia. And if you look at the upper left picture of each of the four map displays, you certainly can see that both patients have an inferior steepening of their cornea and would certainly look like they may have post-LASIK ectasia. The picture on the left, you look at the elevation front and elevation back maps, and you certainly see that the back elevation is more elevated than the front elevation in that same area. Thus, we would have to conclude that this patient on the left certainly has post-LASIK ectasia, and indeed they went through corneal collagen cross-linking to try to slow any further progression of their ectatic disorder. The picture on the right is the other patient. If you look at the central corneal thickness again, it's actually thinner than our patient on the left at 425 or so. But if you look all the way over to the front and back elevation maps, you see that the front and back elevation maps are fairly symmetric. There is really no increased elevation on the back surface. And so while this patient certainly has something wrong with their cornea and bears monitoring over the long haul, I would say that this patient does not have post-LASIK corneal ectasia. At least there's no evidence of it to support it at this stage. So again, this is where if we really truly want to be able to be an expert at not just fitting specialty contacts, but also being able to give our patients true, reliable diagnosis and information about their corneas and their corneal health, having this information and the ability to interpret this information can set us apart in that way and allow our patients to be able to fully trust that we are capable of managing these patients' anterior segment diseases. We also have our ABCD progression display. This is really helpful in monitoring patients for progression of keratoconus. The good news is that a lot of third-party payers now in the US will cover corneal collagen crossing for patients with keratoconus, but in some cases, in many cases, they want to see some type of progression, that the condition's actually worsening. And so when we can provide this type of information to the third-party payer, just to show that there's been some form of progression, this is really helpful for coverage for our patients. It's also useful, again, just from a reassurance standpoint, if it's not changing for those patients who have very borderline conditions and have opted to wait and monitor, we can feel more comfortable with, again, being that provider who can monitor this, their condition, and make the proper decision, or help them make the proper decision when is the right time to seek consultation for intervention. Finally, from the anterior segment disease monitoring aspect of things, for our contact lens specialists, we're probably fitting a lot of corneas that have potential for complications as it relates to scleral lenses. Our graft patients in particular, a lot of times we have to worry about corneal edema, especially as we have aging grafts or high prescriptions in our lenses, et cetera. And this is just a great example of a patient that I had several years ago who had a penetrating keratoplasty bilaterally, probably 25 years prior to when I first started seeing him in 2014. He presented for scleral lens fitting. He had glaucoma and had glaucoma surgery in one eye with a tube shunt, which allowed for the ability to continue him wearing scleral lenses because the tube shunt was something we were able to maneuver around with the lens fit. But coming in several months after he started wearing his lenses, noted that his vision seems to be getting foggier with lens wear. And so 2 years later, fast forward to that appointment, we were able to do a Pentacam and look at his cornea and notice that indeed prior to fitting compared to with his lenses, he was getting a significant amount of corneal edema, close to 8 to 10% swelling in this case with his lenses. And ultimately, this patient was referred back to cornea for a DMEC procedure over his graft and was then able to be refitted back into scleral lenses after that procedure was done. So again, just helping us to differentially diagnose properly when patients may be having symptoms that we think might be related to our contact lenses, whether it's warpage of the cornea, whether it's edema, et cetera. Pentacam allows us to most accurately diagnose ectasias, keratoconus, or post-LASIK, et cetera. It allows us to determine if progression of these diseases is occurring, and it also allows us to find out whether our contact lens correction that we fitted and prescribed is causing complications for our patients at all, and to, again, best serve those patients' needs. So let's move on to contact lens fitting and how Pentacam is useful for fitting the variety of soft and GP lenses that we would fit. Again, I work at a university, School of Optometry, and I teach 75 to 80 students a year contact lens correction. And one of the things that we always point out is that historically, about 1 out of every 5 contact lens dropouts is dropping out ultimately because they're in poor fitting lenses, and they don't realize that, obviously. but pulling those dropouts back and refitting them into better fitting lenses will allow 1 out of 5 of those patients to get back into contact lens wear. And it's a shame that 20% of our dropouts are dropping out because we simply haven't determined the patient's corneal size and shape and chosen a lens for them that's an appropriate fitting lens. So again, Pentacam gives you that information. It's going to give you your K readings, front, back, mean, etc., cylinder. It's going to give you, as you move down to the second star, your corneal thickness measurement. It's going to give you your white to white value, in this case 12.1. This is a rather large cornea, and it's also a rather steep cornea with a mean K at 44.6. So this patient probably would benefit from a lens with more depth to it than your average contact lens. And there are tables and charts out there to give us information about sagittal depth of soft lenses. And so we would want to choose a lens for this patient which leaned or tended toward the deeper end of our contact lens options that we have. So it's important to have this information again, so as we choose lenses, we pick a lens that will actually fit our patient properly. So moving on, I'm going to spend a little bit of time talking about orthokeratology and how we use Pentacam for our Ortho-K patients. First and foremost, when you embark upon fitting Ortho-K, if all goes well, that patient's probably going to be in these lenses for several years. And during that time, things are going to happen with the cornea, and it's going to be a little bit difficult to know whether this is related to contact lenses or if this is just the evolution of the patient's corneal health over time, etc. So it's really important prior to beginning the Ortho-K process that we're able to screen our patients and rule out those that might be at risk for something unusual to occur down the road that would complicate the process. And so this is just an example of a patient that was actually just seen a few weeks ago in the clinic who presented at 7 years old interested in Ortho-K for myopia management. They're about a -2 Dr. Myope. And you can see by looking at the maps, the anterior corneal shape is a little steepish, 45, 45, 50, nothing crazy though. As you look at the corneal thickness, a bit on the thin side, 440, 443, 447, actually rather thin. And as you look at the anterior and posterior floats, nothing too startling for a 7-year-old. But again, one other thing to note is this patient's father does have keratoconus as well. If we look then at this patient's enhanced ectasia display, we do see a little yellow spot showing up on our front elevation difference map. Comparing the two eyes, we see a little bit both on the right and left. And so, this is a patient where I think all things being equal, I would steer them away from Ortho-K and have them look at other options, such as atropine treatment or soft lens correction, perhaps, of their myopia. Another aspect of Pentacam, again, that we talked about and is really helpful is that full corneal data. And for many years, I used to fit Ortho-K lenses and using a software program that could customize the lens really well. But I was using a corneal topographer and it was getting me only, again, maybe 8 to 10 millimeters of corneal information, which is great if I'm fitting, an 8 to 10 millimeter lens. But if I'm fitting a 10.5 or 11 millimeter lens and I'm only getting 8, 9, 10 millimeters of data, that means that I've got to guess a little bit, and my instrument's going to create manufactured data for that last millimeter or two of the cornea. And it's just going to mean that my fit in that part of the eye is going to be a little less apt to be ideal. So, when you look at these Ortho-K lens fits that you see on the screen in front of you, this is on the same patient. The left picture is the right eye. The right picture there is the left eye. Recognize this patient has about 6 diopters of myopia with 250, 275 of cylinder. This is a very highly myopic, highly astigmatic cornea, and you see what are literally look like perfect Ortho-K lens fits on each eye. And you can see the topography there next to the lens picture on eye. And the reason why this was done, this is the first lens. This is a one and done fit on a 6 diopter myope with 250 of cylinder. And the reason is that we were able to fit a lens. We had all that corneal data, so it was giving us a more accurate information about the corneal shape. It's giving us more reliable eccentricity values. It's giving us more reliable data if we want to use a software-based program that's going to create a lens based off the topography. However you go about creating your lenses for your patient, having more data is only going to increase your odds of getting an optimal fit. And so again, having that information all the way out to 12 millimeters of the cornea is going to give you better odds that that lens that's 11 or 11.5 millimeters is actually going to fit really well from the outset. As I mentioned a little bit ago, the fact too is that the Pentacam data is not tear layer dependent. You're going to have issues with reflection-based systems sometimes, and you're going to get the picture on the left here. Now take into account, this is not an Ortho-K patient. This is just a patient who's post-RK, I believe. But these are topographies taken with different instruments of the same cornea at the same time. And what you see on the picture on the right is we've got some tear layer disruption on the anterior corneal surface, and it's giving us this artifact data. It's throwing off our data. Whereas the same eye with the same disrupted tear layer on the right with a Pentacam is giving us clean data all the way through that's not altered by the fact that there's tear layer disruption going on that patient's cornea. So again, less dependent upon the quality of the reflection off the tear layer. It's actually measuring the cornea itself, not the tear layer resting on top of the cornea. There is also on some of the Pentacam models an axial length measurement mode. And so as we talk about orthokeratology, and a lot of our patients probably are in Ortho-K lenses because they're interested in managing their myopia progression. And so the Pentacam, like AXL and AXL wave, the AXL obviously meaning axial length, it's giving you options for measuring axial length for our patients. And here's just a couple examples of patients that are in our system. The picture on the left, this is done through a typical walkthrough where I can get axial length measurements, wavefront aberrometry, and corneal tomography and or scleral topography all through one series of measurements that's all done consecutively, one right after the other in order. So I've got all that data within a matter of seconds. I've got axial length, aberrometry, corneal topography, all taken care of at once. The patient on the left here is obviously a moderate myope, the axial length 25.8 or so. The picture on the right shows a very high myope, again, I think about a minus 12 or 14 with an axial length of over 30 millimeters. So having this in the system allows you to have multiple modalities for monitoring your patients or measuring your patient's eyes all in one instrument. So just save space in your office. You don't have to have an instrument for doing your corneal topography and then moving them to a separate instrument for axial length measurement, et cetera. It's all can be done within the same instrument here. I didn't want to finish up as well talking about how we can fit patients in Ortho-K lenses using some internally integrated software. Pentacam does integrate with a couple of different software applications that you can use for contact lens creation. And so we're going to talk about that. This is a patient here that I fitted a couple months ago, presented with, again, a rather higher, moderate to higher prescription, minus 575, minus 2, axis 165 was the left eye. The right eye was very similar. Here's our corneal maps. You can see a regular curvature map on this eye. You can see front and back elevation maps are symmetric, and you see corneal thickness sitting up around 600. So no reason not to proceed. We went ahead and finished the exam. We inputted the data, and then we opened up our wave software, which is one of the programs that works well with Pentacam. And the beautiful thing again is with the Wave software now, the way it has been redesigned and reconfigured, I simply can choose the night lens module, which is the Ortho-K option, and hit create and enter the patient's refractive data. And the software will go ahead and make me my initial optimized lens from the get-go. And 95 times out of 100, that's the lens I'm going to order right out of the chute. I'm not even going to spend any time modifying it. I'm going to spend just a minute, maybe double checking center thickness, edge thickness, diameter to make sure they're exactly what I want. But if I'm changing anything, it's very subtle. Maybe I've got a patient where for some reason I want to tweak the overall diameter up or down a little bit or adjust the center thickness slightly. Okay, fine. But generally speaking, I'm letting the software do all the work for my initial lens design, and I'm just coming on here and clicking the order button. So we dispensed lenses after 2 weeks of wear. That patient was uncorrected at about 20/20 minus. She's generally happy. She saw better quicker than I thought she would, honestly. But she's still complaining of a little bit of glare and halos. This is a 27-year-old patient, so it's not a child. So she was certainly more sensitive to the glare and halos and distance acuity than a lot of our children are. She's doing really well with everything in general. So at this point, with the cornea already significantly reshaped, I felt we can go back and try to open up the optic zone a little bit to try to expand her treatment zone without running the risk of getting bubbles and things like that. So I decided to just go back in an optic zone, increase it by 0.3 millimeters and flatten the base curve by an extra quarter. And so when you go back into the Wave software, let me jump back a couple slides. Down in the lower right corner, you see the modification area. And this has all, again, been made really simple. So I simply can click on the little picture with the pencil and wrench, and that's going to open up my modification box. And these are the things that I can modify with just a click or two of my mouse. I've got the option of adjusting my alignment zone in the upper left. This is going to be the area adjusting the tilt, if you will, the angle at which that alignment zone rests on the peripheral cornea. I can also increase or decrease the depth of my lens through the reverse zone adjustments. I can adjust the base curve. I can steepen or flatten it. So if my patient's prescriptions progressed and they need a little bit more myopia correction next year, I can always flatten the base curve a little bit. And then the final option would be to adjust the optic zone diameter. And you can increase or decrease the optic zone diameter in 1/10 of millimeter increments. So in this case, I simply click on optic zone diameter change. I've got two options that pop up. I can increase, bottom left picture. I can decrease, central bottom picture. And then I chose increase, and then under the amount, again, I can click from 0.1, 0.2, 0.3, etc. And I chose 0.3. I apply that change along with a quarter diopter change in my base curve. And I simply hit apply, and now I've got a modified lens design, which shows the increased optic zone from 5.8 to 6.1. And my base curve is now, again, a quarter diopter flatter. So dispense the lens and ready to go. And what I know through this process is that I know exactly what the new lens is going to be for my patient. I've done the adjusting myself, but I've done it in a way that literally took me seconds to do that. And so not only does the patient get theoretically a better lens, or at least the lens I want them to have, I know exactly what changed, and I was able to do it extremely quickly through a software program and simply click order. And now my second lens is ordered, ready to go on the way for my patient. So very efficient, very easy, and yet still giving me complete parameter control throughout the entire process. So we'll spend the last little bit of our time tonight going through how we can use the Pentacam also to fit scleral lenses. And before we get deeper into the corneal or the scleral topography and so on and so forth, don't forget, I mean, I still, even though I'm using scleral topography a lot to help me with my lens designs, and even in many cases using integrated software to design those lenses, I always stop and look at my initial corneal topographical or tomographical information first. I want to know the shape of my cornea. I want to look at it and I want to understand it. In this case, we can see obviously a patient with keratoconus with a very centered cone, a fairly nipple center cone that this patient's got going on. And so that gives me an idea of what kind of shape I want my scleral lens to have through the optic zone portion of the lens. And then bottom left in that little star there, it shows 11.5. That's my corneal diameter. So again, I'm working with a somewhat smaller cornea, which means I may want a slightly smaller lens diameter, maybe easier for the patient to work with, and especially in this situation with a patient with keratoconus, I think, maybe I can get away with fitting a slightly smaller lens diameter, making it easier for the patient to handle and insert and apply. So always take the time to look at this part of the things, understand the cornea, even though I'm fitting a scleral and all of the landing is going to go on the conj and on the sclera, I still want to understand the cornea. So I make sure that as I vault that tissue, I'm vaulting it in good alignment, in proper alignment to the shape of the eye. So you may be familiar with the CSP module on the Pentacam. It's been around for a few years and we've been using it with success in our practice. And you see it on the bottom left. The CSP requires 5 scans to be done, a central scan and then a superior, inferior, nasal and temporal. And it stitches those together to give us a very nice corneal topography with lots of good, or scleral topography with lots of good information there. The difference with the CSP Pro is that you have an extended range that the instrument itself can measure out to 16 plus millimeters, probably even out to 18 millimeters if you get the lids out of the way well enough with just a single scan. And so the picture on the right shows another scleral topography, but this was done with just a single scan of the eye. And if you look at the little picture in the middle, you can see the area in yellow. That's the actual data that we captured. We don't have this very bottom sliver. If we wanted that, I could go back and take a second scan and try to capture more of that inferior data and stitch it to this one. But in this case, I was fine going on without that data. Just wasn't that important. So again, the CSP Pro is the newer version of the CSP, which extends. In this case, you can see by the coverage map, I've got my first scan covered in yellow. The second scan we took, we focused a little bit more on lifting that upper lid up higher, and we were able to fill in 100% of data at a 15 millimeter zone and nearly 100% all the way out to the 18 zone. And this is obviously a very complex eye. You can see by the shape. This is a patient actually has a filtering bleb up at 12 o'clock there and was wanting scleral lens correction, not only for vision, but also for managing their severe dry eye. And we were able to use this map with some integrated software to create a very appropriate lens fit, and the patient's successfully fitted with a scan-based scleral lens that works and it vaults up over that filtering bleb beautifully and is able to work very well for this patient. So again, the CSP Pro providing that information that we need to then feed that information into software for lens design. If you prefer to do the fitting on your own with diagnostic lenses, and then I do a good share of my scleral lens fitting with diagnostic lenses because I'm teaching others how to do it, and they won't always have access to these equipment in their practices, so we do a lot of diagnostic fitting. But even as we use diagnostic lenses, we always come back to the lens design information, the data, to help us understand how we got to that point. And so in this case, you can see the data that the CSP gives you. It can give you, you can set the ring diameter to whatever lens diameter you wish to fit. In this case, I've set it for a 17 millimeter lens. It tells me at 17 millimeters with a central clearance that I've preset at 300, but which is adjustable, that I need a scleral lens sag height of 5276. That's really convenient. If I want to grab my diagnostic set, I grab a 17 millimeter lens with a sagittal height of around 52 to 5300. This patient has all kinds of corneal and scleral toricity, so we need a lens with a great deal of corneal toricity or scleral toricity to the lens. And so we can put a lens on that we should be pretty well assured that I've got the best diagnostic lens in my fitting set on that patient's eye. It also helps us because we can change that ring diameter to different core diameters, and we can understand what's going on with the cornea and limbal zones as we fit that patient. So if we want to get more complex with our design, whether it's fitting quadrant specific lenses or fitting dual sag lenses or whatever increased complexity we want to get to try to better fit our scleral lens patients, that data is inside the CSP data program here, and you can simply pull that out by changing the ring diameter to whatever chord you want to look at that shape information at, and use that to better fit your patients with their lenses. And so again, this is simply a patient that we fitted that patient in the previous map by looking at their data. We looked at set the ring diameter to 17 because that's the diameter I wanted to use. Looking at the sag, you can see what was recommended, 5276. We actually ended up splitting that in two and going about halfway in between. Having that be halfway in between our dual sags. We use a dual sag lens with 250 microns of toricity in the internal vaulting chamber, and we were able to then put another 300 microns of toricity out in the peripheral zone, and we created a really nice looking fit on an extremely toric eyeball, simply using the data and almost designing this as an empirically fit lens using the data that the CSP software provided. Now, if you want to, again, there is integrated software and you can certainly use that. Here's a case of a patient who's currently in scleral lenses, but having issues with mild lens awareness and some midday fogging. We look at the lens fit, and it's okay, but it's not great. And so we washed him out of his current sclerals, had him come back and did a CSP Pro. And you see the data coverage we have here in the yellow in the center of our map. And you can see the map on the right, and it looks somewhat irregular. We've got a fairly good extent to a flat zone off on the right side of our map. And then we've got an area where we've got some very deep areas down at 6 o'clock that very quickly rise up into a much higher area. And so this patient would probably benefit from a little bit more of a free-form design than a simply straight up toric or spherical design. So we opted to go ahead and run him and run a pair of lenses for him through, again, using the Wave software. In this case, we simply click the button for the scleral lens design and let the instrument design lenses based off the patient's prescription and whatever other parameters we want to preset. I did choose to put him in a 16 millimeter lens. I set the center thickness and went ahead and put in the patient's prescription. Now in this case, because he's got keratoconus, what I actually used was the patient's previous lens and prescription information, which you can put in the biometric data entry area. You can put in a known base curve along with a known prescription of a previous lens with any over refraction data, and it will then calculate out the proper scleral lens prescription. In this case, we got a relatively good outcome with the first lens. The patient felt much more comfortable and reduced the fogging issues that he was having. But again, if we wanted to go back and make adjustments to our scleral lens with this integrated software, you've got essentially the same module you had with the Ortho-K lens fit, and that is you can adjust your scleral zone, your alignment angle here in the upper left. You can go through and adjust your limbal clearances and your central clearance, your central sag, as well, your central vault. You can do each of these by simply clicking on the box, and then you increase or decrease any of these factors in 10 micron steps and then the beautiful thing, again, because this can be made in a free-form design, is you can modify the entire lens or half the lens or quadrant specific. Any of these aspects can be managed just with the entire lens or with segments of the lens. So you can customize the fit as much as you want to, even down to quadrant specific limbal and alignment angle clearances. Finally, just another case that we had a patient wearing scleral lenses, again, having some midday fogging issues, had tried a variety of ways to try to resolve those. It wasn't getting better. Offered this patient the option of washing out, doing some mapping, and reordering a freeform lens off of a software integrated with the Pentacam. This was prior to getting my AXL wave, so this is with the prior CSP program. So we did the 5 scans. You can see the map. The reason we were getting fogging, I believe, was because of this abrupt change in depth here at 1 o'clock from -153 up to +79, just not even a clock hour away. I think this was having a hard time sealing off. So we went ahead again and pushed her data into our software and created a very nice, this was again our first lens right out of the chute. She noticed a significant improvement in the fogging and even a more comfortable lens than what she had been wearing previously. So again, utilizing the software integration, it's become really, it's very successful with initial lens design, especially if your map is good. If you get a good map, you're going to get a good initial lens. And the difference being now is that the softwares have become more user-friendly and much easier to make modification with, so you can go ahead and adjust those fits and get them optimized over a very short time frame. One thing I want to mention last and not least is as scleral lenses, as we're moving into more and more custom options, not just with our fits, but also visually speaking, correcting for things like higher order aberrations and understanding higher order aberrations in our irregular cornea patients in scleral lenses becoming more important, if you will, and something which is more on our radar. And having the aberrometry measurement in the Pentacam AXL wave is really helpful for me to understand for those scleral wearers who are complaining of residual ghosting or halos or shadows. It really helps us to understand what's going on with their lenses more. And again, I think over time, we're going to see that this becomes a part of more and more lenses to be able to correct these aberrations and give our patients higher quality of vision. And that's something which is already part of the AXL wave. So just to conclude, again, I think I would consider myself a contact lens specialist. Hopefully you feel that way about yourself as well. Having a Pentacam, it certainly elevates your practice in terms of your ability to be not only a good contact lens fitter, but really good at managing anterior segment disease and feeling like, yeah, I can fit your contacts, but I can also manage your anterior segment disease. And maybe you already have somebody you see for that, but it never hurts to have another person with expertise giving you another opinion and helping keep an eye on those things. So I think it really helps in that regard. It's not just a device for the refractive surgery practices anymore. It's increasingly a device for that optometrist, that contact lens practitioner who just really wants to be better and better at what they do and have a better understanding and take better care of our patients in terms of helping them understand and manage their anterior segment disease. It certainly can elevate your Ortho-K lens fitting by getting more information, more corneal data. You're probably going to get better first lens success. It's going to allow you to tackle more complex cases. You know, maybe you say, oh, I don't feel comfortable fitting a patient with 2.5 diopters of astigmatism in Ortho-K lenses. Well, maybe if you had an instrument and some methods for better fitting those patients, you'd feel more comfortable taking them on, because having good information, having good data, having a good instrument, having good software programs to work with as well, certainly makes you feel more comfortable jumping on a broader spectrum of patients. So I think that's also important. And elevating your scleral lens fits, providing better fits, providing a more efficient fitting process for the patient as well, showing them that you're doing it in a high-tech way, that you're understanding the shape of their eye at a high level, And then again, just to be able to provide them better fits and to control modifications personally and understand the shape of the eye to tailor those adjustments, I think is really helpful for our patients as well. So I just want to thank you for taking the time to be with us tonight, and I'm happy to take questions with the remaining time we have.
What a great amount of information, Jason, that you provided, and we do have some really good questions that have come in. I'd like you to comment, though, on a couple of things. Why don't we start off with the scleral aspect that you were talking about? I know the bane of my existence in my practice was if I had more than one scleral fit a day, between putting lens after lens from a fitting set on the patient's eye and sometimes having to go to a second, third, and even sometimes a fourth lens, the patient could be in the office for 3 hours sometimes, and it could really mess up the flow if I'm monopolizing one technician with one patient for that many hours. Can you tell me how has profilometry impacted the way you fit contact lenses, and how has it changed the experience of the patient being fit for a scleral lens for you?
Yeah. So, I mean, it's obviously you can fit a patient strictly off of diagnostic lenses. And of course, then what happens is your first lens becomes your topographical information, if you will. But then you have to put on a second lens and maybe a third lens. And like you said, the process for the patient, it's cumbersome, it's not enjoyable. And you're left with nothing in your chart about that patient's ocular surface other than this lens was too shallow, this lens was too shallow, whatever. Um, and for me and for my patients, I'm much happier to spend that same amount of time it would have taken me to put that first diagnostic lens on, and instead use that 10 or 15 minutes to obtain information about their eye that will be a permanent part of their record, and you'll always be able to look for any changes or issues. That data now becomes a great wealth of information about that eye shape that's now in their chart for good. And that certainly is more valuable than just saying lens number 4 was too shallow, which is all you get from a diagnostic lens. So the process of getting this information is much better for the patient than trying lots of lenses on. B, again, whether you choose to then take that data and just click a button and use a software program to make your initial diagnostic lens, which in our post-COVID world is more appealing to a lot of people than trying a bunch of lenses on, or whether you prefer to diagnostically fit like I do a lot of the time, it just allows you to go grab the first diagnostic lens out of my set. I know I'm one and done because I know that the one I'm going to put on is the best one I have, and I can look at it and maybe I'll tweak the sag by 100 up or down, or maybe I'll tweak the edges by a couple steps, but I know this is the best lens. So for my patient, it's a one and done process. I'll put the lens on. They're often impressed that, hey, this first one you put on feels pretty good, and how did you know this one was going to fit me so well? It's like, well, that data really directed me toward giving you a lens. Your first lens experience actually is very positive. So the whole process has become so much more efficient and professional feeling to the patient than just trial and error. So I think there's so many benefits whether you choose to use the map to actually do lens creation or simply inform you and your process so that you can be very efficient. Either way, it's a win in any regard. So.
Jason, you mentioned one of your cases about freeform design. I know I've only been doing profilometry for 2 years. I've been fitting sclerals for decades. And the thing that shocked me the most when I started doing profilometry on every fit was how toric the sclerals really were and how often they would significantly toric and irregularly toric. And I never really appreciated that, even with my toric haptic fitting sets and things. It just to me was eye-opening, and the problem of midday fogging has really become a non-issue. But can you comment on, like, when do you decide to go to freeform? Is there a magic number on scleral toricity, or what are the factors that make you decide to go to freeform?
Yeah, so what's funny is there's no magic number on scleral toricity. There's a magic number on corneal limbal toricity, because that's where the problem of fogging really occurs. It's very easy to create a lens that touches down on the conjunctiva 360 degrees. It's not very easy to create a lens that touches down over the entire scleral alignment zone of the lens 360 degrees. And there's no eyeball out there that's got, 500 microns of toricity in just the sclera. In those patients where you look at your ring diameter and see a scleral toricity of 500 microns, I guarantee you half of that at least is coming from the cornea and limbus. So my preference is actually to decide on the diameter lens I'm going to work with, roughly speaking, give or take a half a millimeter, and then approximate where that lens is going to touch down on the eye for the first time, not for the last time, and look at the toricity at that chord diameter, not at the full chord diameter of my lens. And if I've got more than 100 microns of difference between my meridians at that initial touchdown point, that's when I'm looking for something more freeform. If I've got less than 100, I know I'm going to be able to make this thing work with a very basic design. Yes, I might add a little toricity into the haptic part, but I know that a fairly straightforward design is going to work. So a little bit of that is just deciding, what's the patient's corneal diameter? Let's say it's 12 millimeters. Move out a little beyond that. So let's say 13 to allow for clearance. And what's the difference in the toricity at 13 millimeters? That's where it really comes to become important, not out at 16 or 17 so much.
That's a great distinction, important distinction. We have several questions regarding the concept of chair time and reduction in chair time. Can you comment a little bit about how, with both Ortho-K and scleral lens, how these technologies have helped reduce your chair time?
Yeah, absolutely. Again, for Ortho-K, increasingly going to the software-based designs, because what happens is you might get a child in your chair who's 6, 7, 8 years old, and that parent who's willing to do Ortho-K for them for vision correction, but also to try to manage their myopia a little bit, they want the best for their child. And if they didn't, they wouldn't be sitting there willing to fork over however much it's going to cost to fit them in Ortho-K lenses. And so when I can do a map of their cornea and I can tell the parent, I'm going to make lenses that are custom made for your child's cornea. I'm not doing it out of a box or something like that. They are all about that. So for one thing, the parents of the children love the idea of something custom made for their child. And the second thing is then what happens is I don't have to spend that time at that first appointment where we talk about Ortho-K and we talk about the idea of fitting them, and then we maybe have this long discussion, and then they decide, yeah, I want to do it. So can we start right now? Well, now I have to decide, do I have time to actually do a fitting, or do I have to come back to a fitting? And what's easier is to say, yes, we can begin now. I'll go ahead and design those custom lenses, and when you come back in a week and they're here, we'll start the process with the first pair already made. And it's just, it makes so much more sense, again, than trial and error fitting, and to be able to say it's worth the week of a wait because I'm making custom lenses for your child. It's very well received by virtually every Ortho-K patient and their family when we present it in that fashion. Scleral lens is much the same way. Again, the process of obtaining that scleral map sometimes takes a little bit of time, but once we have it and we can explain to the patient, this is the shape of your eye, and we do that briefly, we don't spend a lot of time, but an educated patient always, in many cases, is a better patient to work with because they understand the process a little bit better. And then again, like I said, whether it's hitting a design, we're going to make you a custom lens, and when you come back, we're going to have that first lens going. Or it's, let's go get a lens and I can tell my student, go, pick this lens for the right, this lens for the left. They put it on, it's almost there with just the first lens. We over refract and we're ready to roll. Order, and that first lens should be dispensable again 9 out of 10 times. It's just, it's so much more efficient, and there's so much more of that early process that you can delegate rather than putting on a lens and you have to look at it, and putting on another lens and then you have to look at it. It just saves your time, and it's more things that you can delegate to staff to help with. And so again, that just makes for more efficient doctor time.
So Jason, I think that we would all agree that clinically it's a really phenomenal tool. I think one of the other things that you touched upon there that I would wholly agree with is the value of the patient education, and particularly myopia management and parent education. Because now we're talking cash pay. There's no insurance involved typically with myopia management, and having a parent understand why the child can benefit from different myopia management options, whether it's Ortho-K or atropine or multifocal contact lenses. I think the Pentacam has become an indispensable tool for me explaining to parents very quickly what's special about their child, what we're going to do differently than other people do to help their child see better. So I think the patient education piece of it is really also something that I didn't anticipate when I first started doing it. And then I learned pretty quickly that, wow, I have a really valuable tool in my lane, and I need to pull this up and show the parent what's special about their child's eyes and what we're going to do differently than maybe has been done in the past. So I have a couple of questions that are more instrument related that I'll just address real quickly. The rest I'll address via email. One is we talked about the CSP Pro, the newer version of the CSP software. Just to clarify, that is currently only available on the Pentacam AXO Wave model, and the 5-shot CSP is available on the other Pentacam models. And also, Jason, you mentioned the Wave software. That is separate software that can be added on to any Pentacam also. And that you can go to wavecontactlens.com and to look into adding that software to your Pentacam. So I think that's all the time we have for tonight. Jason, thank you so much for teaching us all this valuable information. I want to thank everyone for coming tonight and wishing everyone a great holiday season. Have a great night, everybody. Thank you.